Okay, well, it's about 2 minutes after. And thanks to each of you who have taken the time to join us this afternoon. First and foremost, I want to thank Pam Anderson and Kim Britton for taking the time to put this presentation together, for being willing to do it, and for really doing everything that they've done over the last decade plus to help build this infrastructure for all of our investigators at UB. Some of you may not recognize, but they set up this office not that long ago. 2013 was when it was established, and it was intended to serve as a centralized hub for advancing and strengthening clinical research across UB. Though I have to say, I'm fortunate to meet with them on a regular basis, and the work that they do not only enhances the environment here for our investigators at the university, but I think you all recognize that clinical trial and clinical research are really pillars across our community when it comes to our community partner, our community partnering hospitals, and frankly, and this is the part that I find most inspiring about the work that they do, is that it really enhances the environment for our friends and our family and each of us who are situated in a community that is fortunate enough to have clinical trials an option. Because, I think all of you, your familiarity with the space is that it brings options to people who may potentially be looking at, just the treatments that have been out and available for a period of years. And we all know that the science and research advances so fast. So under Pam and Kim's leadership, since the office was founded, they've streamlined study startups, they've enhanced compliance, which some of you may have heard us speaking about before we started the session. And they have built a team and an infrastructure that supports investigators and all of the other stakeholders that I just mentioned. They've done it in a really short period of time. They've taken us from 0 to 60. And I have to say that they are also integral in the conversations that we have on this topic across the state system. They've been representing the University at Buffalo in this regard with a SUNY-wide collaboration for, I don't know how many years, but they're basically keeping us connected. So I will pitch to them. I want to thank them again for their leadership in the space, for everything that they've done to bring this to fruition. And then give them a chance to tell you more about what they're here to help support and the team members that they have as part of the group. I will also say to you, I was working most recently with a research team, that was a working group as related to clinical trial. And generally speaking, the people that are aware of this office and take the time to loop Pam and Kim and their team into conversations, say nothing but wonderful things about how accessible they are and how supportive. So at that point, I will hand it over. I'm not sure who's going first, if it's Pam or if it's Kim or if it's both. So I'll mute and thank you again to both of you for taking the time to do this today.
Well, thank you for that lovely introduction, Jill. We strive to live up to it. I just want to make sure everybody can see my screen okay. My slide? Okay. So my name is Kim Brunton. I am one of the Associate Directors of the Clinical Research Office. Between me and myself and Pam, we kind of run the gamut. So I handle more of what would be traditionally known as the pre-award state, and Pam handles most of the post-award. So I'm going to start with a lot of the kind of general functions, excuse me, of the research office, as well as kind of ways that you can find new opportunities for research. Especially, we support mostly, I will say, industry sponsored, but we're open to supporting all of the clinical research that goes on. So like I say, we're going to kind of look at how to engage us, what we do, and now we're just going to kind of look at some ways to find some additional research. And this is going to be key and paramount through all of this is communicate. Communicate your interests. Let us know in the research office, either Pam, myself, we have the facilitators through the CTSI. They always get, we always get, kind of cold calls, I guess you would call it, for different study opportunities. So if we know that you are interested, we know where to pinpoint some of the inquiries that we get. Always a good idea to talk to your colleagues. They may have something coming down the pike they may not be interested in. If they know you are, they can pass that off to you. Talk with your department chair. I'm interested in getting into research. We have one department chair, and he picks his guys, and it's like, this is the study, and you're going to do it, and kind of like, will you do it? But with a strong little thumb on there. And we've developed a couple of really good new investigators that way. Most of you will also interact with salespeople or MSLs within the different industries or pharmas that you work with. And they are a great conduit to getting to their research people. So if they know that you're interested, they can put in that word. It's like, hey, Dr. Jones at UB really wants to do some studies in CKD. And, if they've got that in their portfolio, then you will get some things that way as well. As far as things with industry, most of the pharmaceutical houses, as well as the device companies, have grant programs that help fund investigator-initiated trials. And it usually involves an application process. Most of them have things on their website that will lead you through the grant process with regard to that. To name a few, it's like Novartis, Medtronic, Lilly, Pfizer. They all have these grant programs that are available. So if you've got an idea, if you've got investigator initiated and you're looking for some money, it may not be a bad idea to take a look at maybe who owns the product and look at their grant opportunities that way. The other is the VPHS has most recently identified an individual that will help in finding prospects for you. And that is Daniel Fidioki. And he is positioned to meet with investigators one-on-one. He will go over what you're looking for, what the key data points are. He will follow up with anything that he finds in opportunity-wise within a couple of weeks. And his information is here. I'm going to backtrack for just a second, just to say, we're going to go through this fairly quickly. There is a lot of information here. You are going to get a copy of these slides, and everything that is linked. So you will have all of these links available to you when you get the slide presentation. Okay. That being said, the other the way to look at things is through national databases. We all pretty much know about clinicaltrials.gov, and that's the searchable registry through the government for clinical trials. And it's always a good way to kind of see what else is being done, who's doing it. If they're in the still looking for sites process, and always a good idea at that point, it's like, I'm interested in this. Those are the people you reach out to. Center Watch is a organization through WCG, and it has 40,000 plus clinical research opportunities. It's updated daily, and it's a great resource for clinical trials, excuse me, and some clinical research that's going on. The other I will say is for in cancer research, the NCI has their clinical trial search part as well. I mentioned the facilitators a little earlier. They're heavily involved with the Trial Innovation Network, the TIN. It's part of NCATS, and they have that goal of increasing efficiency and effectiveness, especially in multi-site trials. They get opportunities presented to them weekly. And again, this is where it all circles back to that communication. Let us know what your interests are, and we will make sure if those things come across our desk that you are notified. I'm going to move on a little bit and switch gears, and we're going to talk a little bit about who we are in the clinical research office. We are centralized. We are charged with the administrative and financial oversight of all clinical research activities for university faculty members. Human subjects originating any of the health sciences schools pass through the CRO by means of central study registration. And clinical trials from any of the other schools on campus are also must pass through the CRO via central study registration. There is a little bit of a stopgap in the IRB. They know when they are to look for the signs that it has been registered. And if you go into if you go into IRB before you go into central registration, it will be kicked back. The flow, I'll go over in a minute, but the flow is basically CSRs. We are a core office through the Clinical and Translational Science Institute, and we are under the VPHS. So we use the NIH definition of clinical research, or human subjects or materials of human subject origin, interacting with subjects, patient-oriented. And I'm not going to read to you, but it's all here. It does include epidemiological and behavioral studies, always the good things to know. And under that kind of umbrella of clinical research lies clinical trials. In clinical trials, again, we use the NIH definition of a clinical trial, prospective assignment to an intervention to establish effects of health-related or behavioral outcomes. Again, there's a nice little decision tree that is referenced here, excuse me, and it just walks through it. Is my study a clinical trial? And you can walk through that decision tree. It's got different case studies. There's a lot of nice little additional information at this site, but it basically gives you a little bit more insight as to whether you're doing the clinical trial or not. So in a nutshell, these are some of the basic things that we do. Again, I'm going to speak to more of the things on the front end, and then Pam's going to pick up with the budgets, development, and ongoing billing. So as I said, central study registration is where everything starts. That is the biggest place that we can start to avoid redundancy. Central registration started in 2017, and it came about after a survey that we sent out to a lot of investigators and their staff as to what are your big bugaboos, what don't you like. And one of the big things that we heard was that I have to put the same information into 5 different systems. And it's true. If you're doing a clinical trial with various aspects to it, it can be up to 8 different systems. You have to put the same information in. So our main mandate with that was get it in once. We will get it everywhere else it needs to be, as well as start off different processes. One of the other things that we heard was communication. I never know about anything until I've done it wrong. So this also helps with that communication. We can kind of look at your study, identify, do you need additional resources? We can connect you with those different resources. Do you need budget assistance? We're going to put you in touch with Roseanne in our office. Regulatory assistance, that's Lynn. And then the CTSI has afforded us many additional resources that have been very, very helpful to different investigator teams. And so this is kind of a foray into identifying what they are, where they are, and how you reach them. So again, central registration is the first place that you enter it. If your home department is in any of the health sciences schools, all of your studies need to go through central registration. That does include your chart reviews. And I know that there's a lot of chart reviews now that are kind of considered exempt. However, we have a reporting mandate to our institutional partners, and this is the mechanism that we do that with. Excuse me. If you have an NIH-defined clinical trial in any of the other schools, then you also must go through central registration. When it's not required is if you are seeking an exemption or not human subjects research determination, or if you are not within one of the mandated schools and you're not doing that by NIH definition clinical trial. The nice thing about this is PI proxies can be assigned through this, so that in the IRB system, so there's that identification of your staff. One of the nice things is when we look at that, we look at your staff and we see who's done their COI. That's going to hold you up in the IRB if it hasn't been done. So you're going to know at study registration, 3 people on your team have not done their COI. So you can start that nagging process while everything else goes on. The other is, again, that additional support that's needed. We're going to be able to request that through the system. And then as I say, we're going to start at least start all those other things. We are going to start your IRB submission. We will never submit your IRB submission. We will put your contracts in. We will identify any of your contracts that are needed. And if it's industry sponsored, we will also enter and submit your funding proposal in CLIP grants. So the ones that we do complete are agreements and funding proposals for industry sponsored. Regulatory assistance with respect to clinicaltrials.gov. Excuse me, there are 2 CTSI contacts, and that's Lynn Jagosinski and Irmo Yagalani. And they can assist you with any account setup. They've got general facts or questions that they can help you with. And they can also talk you through, does my study need to be registered? Clinical trials, as a rule of thumb, do need to be registered. If it is an investigator-initiated clinical trial, it is up to the investigator to do that. If it's through industry, typically the sponsor will take care of registering that multi-center trial. And then you can see there's a there's a user guide and some additional information here that is linked to. Again, you're going to get all this information. We also help with, if you are looking to get your own IND, investigation and drug application done, or a device exemption, humanitarian use devices. So we've done quite a few of those, and it's a very different system. They kind of fall outside of the IRB, but are kind of governed by the IRB. So it's just a little different process, and we can walk you through that.
Kim?
Yes.
I'm sorry to interrupt. I'm not sure if there's a little bit of an audio issue. I'm not sure if you can maybe move the mic closer, but it was sort of breaking up a little bit.
Okay, sorry. Is that better?
All right. Yeah, that's good. That's good.
Okay, I'll sit forward. Okay, excuse me. The IRB requirements, again, we'll kind of help you along with those. We do have some, I don't want to say canned wording, but if you're having trouble with some of those, how do I word this? Again, we can help you with that. One thing to remember is the HRP 503 protocol document was updated at the beginning of this year. And while anything that has been started or recently submitted on the old template will be accepted, they will not be accepting it as of, I believe it's April 1st. So I would encourage you, if you are just starting, to use the new template versus anything that you may have saved on your desktop or, have been working with in past. It's not too different, but it does streamline things a little bit more. The IRB, they maintain a library within Click IRB of all the most recent documents, and that's where you should be getting your templates because that is the most up to date. Then the other is UB's IRB can be the IRB of record for multi-site trials where you are the investigator, excuse me, and you want to have UB's IRB be the, like I said, be the IRB of record for other institutions. There's a policy that governs that. I would encourage you to use it, to seek that out if you are in that, in that mindset that you are starting a multi-site and you are the investigator. We also have the ability to seed review to a commercial or another institution's IRB. And those are through the two policies that are mentioned there respectively. We get this question a lot. I think I'm doing quality assurance, but I'm not sure if it's research. Well, the IRB has come up with a self-assessment tool that is available that you can walk through the various questions. It's posted in REDCap. The nice thing about it is you get immediate feedback, and that can serve as your documentation that you have made that assessment, that it's QAQI. And so you will get a letter, you'll get an output at the end of that that says, it looks like this is quality assurance, we're not sure. So you may want to you have to put it in through the IRB, but you can still ask that it be assessed as quality assurance. Many of the times you'll see that if you want to publish. It usually, if your goal is to publish, they're going to want to take it through the IRB. And a lot of that is because a lot of the journals actually want that IRB letter that says, we made the determination. But just so you know that self-assessment tool is there and available for you. Encore is our clinical trial management system. It came to us in 2015, I believe it was. And it follows the study through the life cycle of the study. It does enrollment and visit tracking. It has a lot of robust reporting. We do financial reconciliation through there. The nice thing, most recently, we also have a module that is capable of creating a data capture system that is 21 CFR 11 compliant. It is auditable and you can monitor through it. This is great if you are doing a multi-center trial. We'll talk a little bit more about that functionality in a moment, but Encore is one of those things that has come to us and has been a game changer in how we deal with a lot of things. I will say many of you may be aware of the One Epic project that is going on that will integrate UBMD practice plans, GPPC, PALIDA, ECMC, under one electronic medical record. And Encore is integrating with that. So that will, there'll be a lot of functionality that will be available there. You'll be able to see what studies are available. It can actually interact with your patients that way. So there's a lot coming down the pike. Kaleida and GPPC are slated to go live in late May, early June, and everyone else into the fall, October-ish. And there are study requirements as far as what data is collected. We have two mechanisms to do that. One is a full study, and one is summary accrual. And it comes down to what is needed, what level of data collection is there. This is a nice little pictorial about what type of study you're doing and what is needed if you're doing summary accrual, if you're doing a full study. So, excuse me. Again, I'll let you read this over. If there's anybody who has any questions, certainly let me know. The thing with summary accrual, we do ask that you give us as much information as you can with regard to the demos. It doesn't have patient specifics to it. It has basic gender demos, basically that. There are a lot of other university systems that we use, and the Click Compliance Suite I have mentioned a little bit. That includes COI, IRB, safety agreements, grants, and IACUC. So it's all under that one umbrella of Click. We have REDCap. We have Participate in Research, which is our community-facing method of letting everybody know what kind of research is going on and who to contact in the event that they have research that they are interested in participating in. And then we have a clinical research management system, which is a little bit different than Encore. We're hoping that it will be sunsetted because this is our billing system right now, and the communication between us and our affiliates to know what has to be dubbed as research and what is standard of care. Excuse me. So for a lot of it, it will be sunsetted with when Epic is fully functional, because we will have those notifications through that system. It may still be live for some of the things that are not, some of the practice plans that may not be within the One Epic project. This is a live link. Again, we have put together, it's a 3 or 4 page document that identifies the resources, the various computer programs or systems, what they do, what their functionality is, and how to gain access, all that good stuff. It's got a lot of information. It is a nice resource to have on file. You may not need all of the information right now, but it is great to have as you move through and become more active in research. Okay, as I said, the Office of Clinical Trial Development and Implementation are the ones that are kind of taking the lead on the electronic data capture. And Austin Glick is our guru there. His information is here, but he has put together a nice little graph as far as when is it okay just to use REDCap and when is it more advantageous for you to use Advera EDC. And so that kind of information is there. Again, this is on their website. He is more than happy to talk to you about anything. We are certainly trialing our first study with EDC right now. And the one thing I will say is if you plan on using it, plan early. If you are doing a multi-center trial and it is supported in some mechanism, then it really does, Austin's effort really needs to be written into that grant. So engage Austin. My take home on that. Contracts versus agreements versus grants. Kind of without saying, contracts are kind of your most legally binding. They have great expectations. They have performance, specific deliverables, timelines, etc. Agreements are a little bit more broad. Usually get into like your CDAs, DUAs, MTAs, members of understanding, those types of things. They're a little bit more broad. And it really depends on the terms and conditions as to the degree of which they're enforced. Grants are usually financial assistance and support of something for the public interest. So we all know that with grants, either through foundation, state, federal, they can be different. Local, we've had some things through Erie County, those types of things, but they do have a little bit more flexibility in their execution. There's fewer strings to them. And it's more on advancing knowledge versus anything more on the commercial side. So I kind of went through a little bit of the various types of contracts and agreements. I'm going to hone in on the facility use agreement. When we use services or products at one of our affiliates, Collider ECMC, we need to have a facility use agreement. And what this does is basically lays out the terms of how we use their facility and what we have established as pricing for any of those services that we are using. And to me, this becomes very important. We have research pricing established. And so these are written into these agreements. So when we know that you have an MRI and it was under this study, and you would normally, or a patient would normally get a bill for $2,300, and we have a negotiated rate of $830. You're getting, your grant is only going to be charged the $830 because we have written that. So it's always a good idea to reach out to us with regard to anything that's happening, especially in our affiliates, to get research pricing. That goes whether or not you are doing industry sponsor or if you are doing anything with a grant. If it involves our affiliates, please reach out to us. They have fees that are associated with them just because, and just because they're reviewing it or things are being done within their facility. So you want to make sure that those are covered in your grant because they're coming out. So if you haven't accounted for them, then you're going to have to on the backside because they are fixed prices that are going to have to come out. Agreements are signed not by UB, but by the RF on behalf of SUNY. And this, I cannot stress enough, there is no agreement whatsoever, no agreement, no contract, none of that can be signed by any of the PIs or their staff on RF's behalf. So this means when you get that NDA in, it needs to go through the system. Otherwise, if you sign it, you're the one on the line for that. So it's just, it's to protect you more than anything, because there's certain languages that we can agree to and certain that we can't. Research training. Most recently, we have established a mechanism for coordinator training as well as investigator training. We have a formalized process through a STAC education, which is a virtual and one-on-one what do you call it, system for doing that. We also do some shadowing. The CV Candifer in our office is responsible for that. As far as the investigator training, we do a lot of the same types of things. We don't have the formalized training, but our facilitators, Alexis O'Brien and Marshall Brooks, are our go-to people there. So with that, I am going to turn it over to Pam. And while she pulls up hers, I'm just going to ask if there's any questions that I can answer quickly while she gets all set.
Hello, thank you, Kim. Can everyone see my screen?
Yep.
Okay, great. Thanks, Kim, for that. And for this part of the presentation, I'm going to just go over budget development, the coverage analysis, some financial reporting, and the debit card program. So there are different types of budgets depending on the sponsor or type of project that you're working on. Typically, what we see in industry are fixed price contracts, which mostly are seen in industry, where the costs are broken down by fees based on the procedures and the schedule of events in the protocol. Grant or federal budgets, the funding is provided up front based on salaries, fringe, travel, supplies, and other direct costs. Usually is itemized by year, and cost reimbursable would be based on actual expenditures. Depending on the type of funding, institutional fees may apply, so make sure to contact the CRO for some of those fees. Also, when you're creating your budget, keep in mind some of the hidden costs that might not be in your budget template, like data entry, trainings, both protocol and maybe there was a portal training that you're going to be required to take. We see this a lot in industry. Lab inventory management for those that have central labs, processing, and also compounding of medications or device accountability. And I have an example here of some other costs that you might want to consider when negotiating your budget. I also want to call out the affiliate fees and institutional fees. Our affiliates, if the research is being conducted at their facility, there are charges for that. So again, make sure you loop in the CRO. The CRO will initiate the contact with the sponsor and provide specific budget terms. The final goal is always to have the budget that covers the cost of conducting the entire research project. I did mention if you're purchasing services from outside of UB, Kaleida Health, ECMC, GPPC, or Great Lakes Medical Imaging, as just a few examples, make sure to engage the CRO for the correct pricing, because we do, as Kim mentioned, we have special rates for federal, industry, and departmental funding. Also, you need to be aware of the F&A rates because they do vary whether they are on campus or off campus, and also the federal versus industry rates. For industry, we're at 32% TDC, and the federal and federal flow-through clinical trials is at 26% MTDC. Also for industry, especially pharmaceuticals companies, the budget that you're provided by the sponsor is really only a draft and should not be considered or agreed to until it's reviewed by the research office. Most of our industry budgets, we do see increases of 40 to 70% from the initial budget. So the PI will always have a final say, but again, make sure to engage the CRO in this negotiation. And Roseanne is the contact here for budgets. Some other examples of site level costs, we always have startup fees, monitoring fees, and the institutional fees would be the coverage analysis and the PI oversight fees that we always include in all of our budgets. For more complex studies, you also want to keep in mind that there may be additional fees like setup fees, especially with our institutional partners. If they're building order sets in the EMR, we see that for inpatient pharmacy studies, or if there's specific training, such as we see in radiology. Some of the protocols have manuals for imaging, and they're requiring additional training from the technicians. So we always try to include some compensation for their time for that. All services and studies that require services from non-UB facilities will have pricing listed in the facility use agreement. And this really ensures billing compliance and that our services are not under or overpaid based on the funding. And again, the CRO will always send the budget to the study team to review prior to finalizing. The Encore team, it will create a billing grid based on the scheduled events in the protocol. And this is what we call the billing grid and/or coverage analysis, which is required for all clinical research studies, device and drug, in which test or procedures that are associated with the study could potentially be billed to a third-party payer. So this grid will be sent to the PI, and study team for review and approval. And it's really the PI's responsibility to let us know what is standard practice versus research only. If insurance can be billed, but the test really is for the research study, we want to make sure that we bill the study. Also note with the Epic implementation, this is going to be crucial for the study teams to review and confirm the billing grid is accurate, since this will drive the billing designation from Encore into the EMR, which will result in billing either research or the insurance. And I just have an example of a CT scan as part of standard of care. We're going to bill the insurance, but if it's for research, we want to make sure that we bill the study. Here's an example of a billing grid with the billable procedures noted as research and standard of care billable to a third-party payer. Communication of the billing designation is provided through CRMS, which is one of the UB systems that ensures all the claims are coded correctly. And if your study involves any inpatient procedure, it's required to have this information noting the billing designation entered in the research management system within 24 hours of the procedure. It really not only prevents the patient's insurance from being billed and the avoidance of additional copays for the patient, but it also ensures that claims are coded correctly and avoids the denials. And again, I want to mention with Epic, there will be additional training and probably a change in this process. So to be continued. Some of our vendors also have a different billing process. So again, I can't emphasize enough to involve the CRO to avoid billing mistakes. And when these charges are billed and identified as payable to research, all the invoices are sent to our office where they are reviewed for accuracy and noted, confirmed of the proper rates before they are processed through ShopBlue. So we really, again, the importance of the facility use agreement and also having those special prices on file so that we're not overpaying or underpaying for any services. Encore was purchased back in 2016 to track protocols, study participants, and financials. And we really saw it's been a huge benefit in our revenue, ensuring that our sponsors are paying what they should be paying us based on the protocol. I think prior to Encore, we were probably leaving, I can say millions of dollars on the table because the billing and invoicing to sponsors based on the schedule events has become very complex now, and it's very easy to leave money on the table. So the billing grid is built in Encore, which drives the financials in the budget. The research office has been delegated as the representative for the financial management and reporting of studies within Encore by the VPRAD, and I have a link to the policy. We also offer training for Encore prior to accessing the system. As I mentioned, the budget is built in Encore based on the scheduled events and the billing grid. And when the study personnel enter patient visits, they're tracked in the financials console, which generates invoices to sponsors. Additional items that might not be included in the billing grid, and I mentioned a few of them earlier, maybe monitor visits, serious adverse events, annual fees, and unscheduled visits and amendments. So again, it's extremely important to have this data entered by the study team so that we can not only reconcile payments, but also invoice sponsors for any of those additional items not included in the billing grid. The financial team also runs reports based on what's entered in the system, so we can invoice more regularly. And for any payments that are not received within a certain amount of time, typically our goal is 90 days, are also followed up on. It's also important to update CLIC when your study is approved, so the information can be added to Encore. Some of our contracts, I should say, are tied to invoicing for startup upon IRB approval. So if CLIC isn't updated, we're not receiving that notification, which will delay us in invoicing the sponsor. And we don't want to do that. We want, you to get your money as soon as possible. It's also important to update CLIC for any study or staff changes. I did mention about data entry, but I really can't emphasize enough. We talk a lot about Encore, but it's extremely important for the study staff to be entering the data in the system timely so that we can not only reconcile payments, but it also helps in our reporting, which I'll also discuss, so that we can see what is owed by the sponsor. Here's an example of some of the reporting that we provide on a quarterly basis. Elliot in our office sends that out. Some departments want it more frequently, but typically we do this on a quarterly basis because most of our sponsors pay quarterly and not monthly. So the information is pulled from the report center as well as Encore, and provides a breakout of institutional fees, such as the IRB and the PI oversight and CTMS fees in a separate column. And it also can show estimated revenue, which I mentioned is one of the reasons why we like that timely data entry from the study staff, because based on what you've entered today, it will show up in the estimated revenue column of what you could be looking at receiving a payment for. Another program that's offered by the university is the prepaid debit card program. This was established in 2020, and it is the preferred method to pay our research participants. It can be used in both non-sponsored and sponsored funding. It cannot be used with IFR funding. It eliminates the cash handling entirely and allows funds to be accessible to participants more easily and readily. These are live links to go on the Administrative Services Gateway, and you can set up the request for the cards through that system. There are also different cards available. and depending on your study preferences. The most widely used is the Focus Blue card, which is like a Visa gift card, and that is of no charge. Once you've submitted your application online, the financial team will reach out to you and set up a training and show you how to log in, register, fund the cards, and complete the reconciliation. One thing I do want to mention, when you're setting this up for your participants, you might not want to set it up for all participants that you expect to enroll through the life of the study, because they will change or transfer those funds to the US bank account. So if you have received, let's say, a $5,000 startup, but you anticipate to enroll 20 patients and you're paying them $300, it's going to remove a large chunk of that, which will be uncovered. You won't have access to it. So just food for thought. I would suggest it's better to start with a smaller amount and then you can always add funds later. This is a change from last year. It used to be the threshold for 1099 reporting was 600. That was changed January 1 to 2,000 or more across the calendar year, and that's all studies in the research foundation. So it's not just your study that will be tracked. And so if your participant receives more than 2,000, they would be required to complete a W-9 form. Again, I would recommend, if you feel you're going to get close to that threshold, having your patient or participant complete it at the beginning of the study, so you're not chasing them at the end of the year to complete it. And the UB card program reviews all the data in December, and they'll reach out if they need more information. That's it. Now I can stop sharing
Thank you to both.
and answer any questions you may have.
Please feel free to raise your hand or put any questions in the chat. I just want to thank Pam and Kim again. I think when you sit and you listen to them over the course of 45 minutes or 50 minutes, you can understand the complexity of the space that they're navigating. But at the same time, you also realize how knowledgeable they are in the space. So tap into them if you have not already. It's a tremendous resource here on campus, and the university is a very large place. Sometimes people are aware of some of the infrastructure that we have in place to support, and otherwise we don't. But they are of the same philosophy that Dr. Bashir is in the VP's office is when it comes to wanting to make things easier for investigators. So with that said, does anybody, I don't see any hands up and I don't see any questions in the chat.
There's two in the chat there.
Oh, really?
Yeah, and the links to the general information and the talk in the slide deck. And yes, we will get that to Jill for dissemination.
Yeah, sorry, those were from earlier. I have I've pushed out. If you could just take a minute to respond to the poll that we have. This is not about Pam or Kim or the clinical research office. It's just basically it helps our office in figuring out the effectiveness of the programs that we're putting together. I would encourage you, we do have a YouTube, Health Sciences YouTube channel that actually much easier for people who couldn't make things work based on scheduling to find the information. So if any of you are active in the space or you have team members, I would encourage them to go out and look at the YouTube channel for the recording of this. And that will usually be available probably by Friday. We have a student that works on that for us. So anyone else? Questions, comments?
I just want to thank everyone for their time, actually. And, we have a great team, a great office. And if you have any questions, always feel free to reach out.